for this kind introduction. You see this white field up over there. This is a problem of the computer system here. And I just want to emphasize that many things we are presenting from the Martini Clinic are, this should be the logo of the university hospital. We belong to the university hospital, and many things we do in close cooperation with Margaret Fish, who's sitting over there, and it's an excellent cooperation. So biochemical recurrence, what does it mean? First of all, we have to think about what biochemical recurrence is. And there are a couple of definitions out there in the literature, ranging from 0.1 PSA and rising up to 0.6, and it makes a big difference how the surgeon judges his surgical series with the PSA level. So we have the help from the guidelines, certainly. EAU guidelines say 2 rises above 0.2, and the German guidelines are just in the same line, 2 rises above 0.2. This is pretty good, I think, to compare surgical series, but it might not be the best definition of biochemical recurrence regarding every endpoint that you want to look at. And I want to give you an example for that. Or first I want to give you an example on how it can change your effectiveness of surgery comparing different endpoints. And this is a study from the Mayo Clinic that really impressed me with Horst Zinke as the senior author. And you see here that the 5-year recurrence rate, tremendously different when you choose 0.2, it was 62% survived without progression, or 78% if you choose 0.6. So if you read a presentation in the literature, just look how the endpoint is defined, because it can make a tremendous difference. This is another study that I really appreciate and I really like to read. It looked at more relevant endpoints such as metastasis-free survival and cancer progression survival. And what they found out in this study, this is coming from the Memorial Sloan Kettering, they looked at different endpoints and looked statistically whether they are associated with the endpoint they were looking at. And it was metastasis-free survival, and they looked at 10 different definitions like 0.1, 0.2, and so on, and finally found that 0.4 and a consecutive rise has the best and closest statistical association with metastatic progression and cancer-free survival. So it really depends a bit whether you look at cancer-free survival, whether you want to judge your surgical series, effectiveness of that. And I come to the first message of my talk. I have 2 messages here. The first message is, look, if you think somebody's a candidate for radiation therapy and he starts to rise with the PSA, I wouldn't necessarily wait until he has fulfilled the official criteria for PSA recurrence, but I would rather start him on radiation therapy. And this is something that I want to show you some examples from our database. And this is kind of a plea that if you think you should radiate somebody and he has already a PSA of 0.1, I think just do it. And we are just preparing a study together with Thomas Wiegel, who is sitting in the background, showing that, first of all the patients who reach 0.1 will rise, and Thomas Wiegel will show that patients with PSA below 0.2 but with evidence of recurrence have a higher cure rate when they are radiated than when you wait longer. So what did we do? So the question we had came from a clinical case that happens a couple of times, and I just want to give you this example. It was a 62-year-old man that we performed a radical prostatectomy on in 2008, typical histology PT3A. He was PSA negative for some time and then slowly rised. So he presented to me in April 2011, and he said, look at this data, you don't have to be a urologist, I want to get something, I want to do therapy. And I told him, yes, but you don't have reached the official endpoint, you don't have recurrence officially. But then he told me, you don't need to be a urologist to see what's going on here. There is evidence of disease and I want to have treatment. So I said, okay, I sent you to our radiation oncologist. And actually he came back from that, and our radiation oncologist denied to do radiation therapy because he said, we have these guidelines, important that we keep close to the guidelines, I will not do it, come back in 6 months if the PSA rises. And then we thought, okay, let's look at our database, see what really happens to those patients that approach the PSA level of 0.1, what's going on with these patients. So this is our aim of the study, what's happening between 0.1 and 0.2, and we looked at 157 patients. We excluded, so we really, really carefully looked at every patient of this series. They must have had at least 3 further PSA values once they've reached 0.1. The median PSA value were 6. It's kind of difficult because sometimes patients get immediate therapy. So we excluded all these patients. So we have pure PSA history at a very, very low level. And the study was based on finally almost 140 men. So the message of this thing is you just have to wait until this PSA rises. We did not see some of these sometimes reported anecdotal statements that patients stay at a PSA level of 0.15 and they are stable with that. We didn't see that in our database. We saw that it was just a question of time that the patient rises with the PSA. So if the patient has reached 0.1 and after 12 months, almost 2/3 of them were above 0.2. After 2 years, 82%, and finally 90.6%. And we lost 9% of follow-up, and that's the reason why it is not 100%. So the message is, if the PSA reaches 0.1, you think it's a radiation candidate, I would radiate this patient if he wants to. So looking at the history of recommendations when to start salvage radiation therapy, if you look at the historic data, it's a continuous drop of recommendation, of cutoff. And you see it started in 1995 with lower than 2.5, and the latest was below 0.2. Now the official recommendation is 0.5. But as I said before, maybe you think after this talk to give it sometimes earlier than you thought. So does the big question we have, and I think we have not solved, and I don't see that we can solve it in the next future, is whether we can differentiate between local and systemic recurrence, which would be a very important thing when we think about radiation therapy and the consequence of a PSA rise. The problem that we have to indicate the radiation therapy as the only curative option we have in this situation at a very low PSA level. And I do not see any imaging technique at the moment that is sufficient at these low PSA levels. And I listened very carefully to Christopher Eislin's talk yesterday, and when we looked at local recurrence, I think the median PSA was 2 point something at local recurrence. This is far beyond when we need it for the decision-making process to indicate radiation therapy, and that is the problem, I think. So how can we differentiate and identify patients who benefit from radiation therapy? This is a study that made it the other way around. They looked on those patients who received salvage radiation therapy and benefited from this, and then looked what were the criteria of these patients. It's a very nice presentation creating a nomogram, and you see that the prediction, if you use this nomogram and you get a percentage of whether the patient will be cured by salvage radiation therapy, and the predicted and the actual occurrence of cure is pretty much matched pretty well. So what were the factors? They looked at 1,500 patients. The overall no evidence of disease at 6 years was 32%. It was the PSA level again. It should be lower than 0.5, and then half of the patients were cured at 6 years. And it was the PSA prior to radiation therapy that drives the cure rate, the Psa doubling time, surgical margin, and so on. So I think this is the best study we have at the moment to identify patients who benefit from salvage radiation therapy. On the other side, and this is the second message of my talk, the natural history of PSA relapse is long, and we have to think whether we want to give radiation therapy, whether we want to start hormonal therapy. We will have a talk later on immediate or deferred hormonal therapy in case of relapse. And the natural history is long. We have to take that into account, and we have to look at comorbidity, on age of the patients, and so on before we indicate further therapy. This is again a study from our clinic showing that, and Professor Hulan has already showed this slide, showing the tremendous difference between biochemical recurrence and cancer-specific survival. This is a series with all patients had a follow-up of 10 years, not calculated actuarial survival, at least 10 years. And we saw that as many others have shown before, the cure rate, PSA recurrence rate is very low, and it's a 35% difference in PSA recurrence between PT2 and PT3A. But when we looked at cancer-specific mortality, there was no significant difference, and I think that's a very important message for our patients, not only to look whether the cancer is organ-confined or not be completely focused on PSA, but as well to realize that there's a lot of therapies behind that the natural history of PSA is long. And I think it's a very important message, which I tell my patients with PT3 cancers. It's not organ-confined. You might experience biochemical recurrence later on, but you are not harmed by this. So this is in line with many other publications on that, and I think the most important study and the first that really addressed this problem, the natural history of PSA relapse, came from Pound and co-workers. They showed that PSA recurrence, if it is there, it occurs at a median of 3.5 years, clinical progression at 8 years, and cancer-specific deaths 13 years, and there were 7% of those who recurred finally died at a point in time of 13 years, so it's quite long. Another study from Herb Lepore's group showed that there's no difference at 10 years, pretty much to what we saw in overall survival in men with or without biochemical recurrence, because this is due to the long natural history, but as well to the effectiveness of adjuvant of salvage therapies we can offer these patients. And in line again, a study from Memorial Sloan Kettering, at 15 years, there was no difference in cancer-specific and overall survival in those who experienced or experienced not a biochemical recurrence. An excellent overview was published a couple of years ago by Eric Klein, Matthew Simmons, and Andrew Stevenson, and they revised the 9 studies that were out in the literature at that time, and they concluded that if biochemical recurrence is found, it usually occurs at 2.5 to 3.5 years. Then the clinical progression takes roughly 8 years to be seen, and cancer-specific deaths 10 to 13 years. I want to go back to our database. We just looked at almost or more than 1,600 patients with a completed follow-up, and tried to reproduce what is shown in the literature and shown in the study I just mentioned. And so all these patients had a median follow-up of 6.5 years. We looked at clinical progression, overall survival, and risk factors for clinical progression. And just want to point out, these are all patients, 1,600 from our database, that were 16% with a PSA relapse. So we only focused on those men with PSA relapse, more than 1,500 patients. So the likelihood that these patients were free of metastases at 5 years was 91%. All patients experienced biochemical recurrence. 91% had no evidence of metastases 5 years later, and 81% had no evidence of metastases 10 years after surgery. So what were the risk factors? I don't look at the univariate analysis, only at the multivariate. It was the time in months from surgery to the evidence of biochemical recurrence. That was the most important predictor, and the Gleason grade. And interestingly, it was BMI. We don't understand why it is, but at multivariate analysis, it remains a independent predictor. Overall survival, again, all these patients with biochemical recurrence, we looked at whether they lived at 5 years after they experienced. Yes, 95% lived, and 83% still were alive at 10 years after they experienced biochemical recurrence. Again, multivariate analyses, and it's again the time from surgery to evidence of biochemical recurrence and the Gleason grade in the specimen that independently predict or were associated with overall survival. These are the studies I already mentioned, and it's pretty much in line with what we saw in the literature. So, for example, the year to biochemical recurrence, it was 2.1 in the Johns Hopkins series. It was 1.9 years in our series. The only difference we found was that the time to death was much shorter in our study. So if a patient, when they died, in the time where we observed them from prostate cancer after they experienced biochemical recurrence, it was sooner than we saw in the Johns Hopkins series. And we thought a long time about this phenomenon. And I think the explanation is that The median follow-up is just 6.5 years, so we don't have those patients who later die after biochemical recurrence. We don't see them at the moment, but we probably see them in the later years, and then I assume that this time will be longer. So, natural history of PSA recurrence. Not all PSA recurrence will lead to clinical progression. I've shown you that. The literature is pretty much straightforward in this regarding this thing. How can we identify clinically relevant PSA progression? How can we differentiate local from systemic progression? These are the most important questions. And going back to the literature, I think the most important thing is PSA doubling time. And the best study, I think, so far published on this question is coming from D'Amico's group. And what they showed is the cancer-specific and overall mortality stratified by PSA doubling time. So this study shows that at 5 years, these are different PSA doubling times. It's less than 3 months or more than 3 months. And if you see that if it is less than 3 months, that at 5 years, 1 out of 5 patients has died from prostate cancer. And this is overall and cancer-specific survival, and you see that the curves are just overlying because in these aggressive cancers, it's pretty much the same. If a patient has such an aggressive cancer, he will die from prostate cancer. On the other hand, if he has a slow PSA doubling time, the cancer-specific survival is pretty good, and you see there's a difference in overall survival because these patients have time to die from something else. But on the other hand, PSA doubling time is very important, but it's not everything, and there are some studies out looking at that as well. Even though it is an important factor, Patel and co-workers could show that those patients who had a clinical progression, 43%, almost half of those patients had a higher doubling time. And another study that was really pretty impressive said that if those patients who die from prostate cancer, the majority of them had a doubling time more than 3 months. So what the literature tells us, this is a very bad thing if somebody has a short doubling time, but certainly patients will die or can die from prostate cancer even with longer doubling time. So let me conclude. We have several definitions of biochemical recurrence in the literature, and they correlate differently with specific endpoints. Maybe 0.1 and rising is the best endpoint for indicating salvage radiation therapy. Maybe 0.4 is the best to predict metastasis-free survival. I think, and that was the first message, 0.1 and rising is a good indicator. If you think somebody is a radiation candidate, just go ahead. The natural history is long. Consider this for patient counseling, and the doubling time seems to be the best marker to identify relevant disease. Thanks.
Thank you, Markus, for this really wonderful overview. Are there any questions from the floor? Yes.
Yeah, I have one question, Markus. And I don't think we know very much about the biology of these local relapses we have. And you say if we irradiate them very early, we have much better results. And what that would mean that these local recurrences very early metastasize. That's the only way we could have a better effect if we irradiate them early enough. But could it not be the other way around, that a population, including those with very low PSA levels, is very different from a population including men with only high PSA? So what we actually do when we look on these with PSA is we're not looking on the biology. We are more looking on different populations with different chances after radiation. You understand what I mean?
I think I understand, yes, but we don't have any information to go in the direction you're pointing out. We don't know about the biology. We just have to make a clinical decision. And that's what I meant. I didn't say you should go on and radiate every patient who has a PSA of 0.1 and rising. But if you think somebody's a candidate, then do it early. That is the message of my talk.
I can agree with that, especially from a psychological kind of view. You want to be treated. And the problem is we have no imaging technique, which is not possible. But there are some reports that we have about 50% sensitivity at the PSA of 1. And I would just like to know how serious it is to wait a little until we can have an imaging showing a local recurrence. And I don't think it's yet really clear that it is that dangerous to wait.
I would like to ask Thomas Wiegel about can we wait until the PSA of 1 until we see a local recurrence? And Christoph will. There was one question from Christoph.
I think it's not recommended from the literature because you have, if you take, for example, with a PSA of 1, when you have a sensitivity of a chance of about 50% to see the local recurrence, then the biochemical progression-free survival after 5 years is about 40% less for this individual patient. But I agree with you both that we have to find the ideal candidates for irradiation, not everyone, that's clear. But these ones with positive margins, an early PSA recurrence, a persistent PSA, a short doubling time, these are the candidates for my personal feeling. And the next step is, that's a study from the RTOG. It's not been published until yet, but it has been presented. The combination with additional bicalutamide opens new questions in high-risk patients. But I think it's correct, no waiting.
Now my question, Markus, goes along with that of Jonas. When I looked at Dave Paulson's database 15 years ago, what happened out of the radiation therapy patients who had salvage radiation was that 10 years after their radiation, only a third had benefited from the radiation. All the others would recur. So it means that if you are very aggressive, of course, you have good numbers for the moment, but you may irradiate quite a few patients that do not need radiation. And then, of course, comes the problem of selection. As you very well say, imaging for the moment is not up to the level. And then we have the doubling time. But if you choose to irradiate patients so early, how do you have the time to measure the doubling time? You see, and this is why I would go along with Jonas saying, let's wait a little bit more. It's not so sure that those patients that you irradiate at 0.5 of 0.8 may be less well treated by radiation if we wait a little.
I completely see the problem, and this is a dilemma we have. We don't see whether the patient needs radiation because we don't have imaging and nothing else. But on the other hand, we have to make the decision, otherwise we miss the window of curability. And this is a dilemma which I cannot solve.
But then the cost is that 2/3 of patients will have side effects from the radiation. They may become impotent, and they may have all the problems of bowel, let you know.
Yeah,
so it's a high cost.
It may be a high cost, but I do not see that the morbidity of salvage radiation therapy is such a big problem these days. And that is the thing where I'm rather keen to indicate radiation therapy. But you're absolutely right. You do a lot of patients who don't need that. Professor Wirth has another comment or question.
I want first congratulate you, excellent talk. And I have a little bit of disagree that radiation therapy, which was done 30 years ago, was completely different from today. And this is what we also have to learn as urologists. So we cannot use data from even 10 years ago with adjuvant or early radiation therapy. And I personally do completely the same. If PSA is above 0.1, I tell the patient that he should undergo radiation therapy unless he is very old and sick. Then not, because he never will then die from prostate cancer. Then it makes no sense. But if this patient is young and has a good life expectancy, I think it's perfect to do that. And we have also the data now in the literature. But Thomas, you will tell tomorrow about PSA recurrence in radiation therapy and when to start treatment, salvage treatment. Would be great to hear that tomorrow.
Okay.
Well, just a great talk, Markus. All this discussion boils down to the fact that we need studies. If half of people say 0.1, 0.2, doubling time, we need studies. And there's a large international studies led by Charles Catton Radicals, which hopefully will address these questions.
Okay. I think it's time for coffee break.
Well,
right?
okay. I would say thank you very much for the